Today's episode of Beyond the Mask is presented by the insurance specialists at Bright Think Wealth Strategies. Find the disability insurance coverage that fits you best right now. Email Robert Smith at rsmithjr@financialguide.com. The show is also made possible by the team at CRNA Financial Planning. Get a free consultation today to be guided through the complexities of investing and financial planning. Just visit crnafinancialplanning.com. We'd also like to thank Helping Hands and OSA EMR for their support of the show. And don't forget, listening to our podcast can earn you Class B credits. For more information on how you can submit them, check out the CE Credit tab on our website, beyondthemaskpodcast.com. Welcome to Beyond the Mask, Innovation and Opportunities for CRNAs with Jeremy Stanley and Sharon Pierce. We know you spend your day caring for your patient's best interests. On our show, we want to care for you. Join us as we leave the operating room and learn the latest in the CRNA industry. Beyond the Mask starts in 10, 9, 8, 7.
Welcome to Beyond the Mask. I'm Jeremy Stanley, and I've been working with CRNAs for over 23 years, and I'm married to one. And my co-host is
Sharon Pierce.
Sharon's a practicing CRNA for over 20 years, a past president of the AANA, the NCANA, and she's held many other leadership roles. As usual, our goal with every episode is to educate and enlighten CRNAs, and I think our topic today is definitely going to do that. And Sharon, what time is it?
It's time to wake up, Jeremy.
I think it is. Well, good afternoon, Sharon. How are you today?
Oh, I'm doing great, Jeremy. Thanks for asking. It's been a heck of a morning, though.
Well, I knew whenever I signed on with you and you were eating a chicken wing as fast as you possibly could, it must have been a pretty rough day around the operating room.
Yeah. Oh, well, I started at 5:30 this morning. I was in the endo clinic, and I did 24 or 26 procedures in about 7 hours. So it was just crazy.
So you were rolling, turnover.
Absolutely. Well, that's what it's all about. So I got it done. Run in, and here we are.
That's right. Well, we have a wonderful guest and I think another great show lined up today. We have with us today Dr. Prasad. Dr. Prasad, welcome.
Oh, thank you, Jeremy. Hello, Sharon. How are you? I'm sorry about your hectic schedule.
Well, you know how it goes.
Well, we're going to be talking about a topic today, Sharon, I know that you're intimately involved with on a daily basis, and that is surgical procedures. And Dr. Prasad, why don't you tell our listeners a little bit about your background, and then if you want to introduce our topic, that would be great as well.
Yeah, thank you, Jeremy. Been a practicing surgeon for 30 years, and my history really starts with coming to this country. I was born in India and came here when I was a year old in 1962. And we came by ship on a 30-day journey, which was common at that time. And very interesting, my mom was telling me the other day, she said, Sanjay, the reason we came here was we were looking for a solution to a healthcare problem in the family. We were looking for a surgeon. Isn't that amazing that we went halfway across the world to try to find a surgeon and a solution? So I grew up in the Washington, D.C. area, became a surgeon, trained here, and began my practice. I've been 30 years into practice now and helped tens of thousands of patients. But now I want to help patients get connected to the best-in-class surgeon in their network and avoid unnecessary surgeries and have the best possible outcomes that they can achieve.
But what kind of surgeon are you, Dr. Prasad?
So my field is called neuro-otology. And so I'm board certified in ENT, otolaryngology, and did 3 fellowships at University of Pittsburgh in neuro-otology and skull-based surgery. So what that means for the layperson is tumors that involve the inner ear, the brain, cholesteatoma, which are skin collections in the middle ear, facial nerve issues, cochlear implants. That's the kind of microsurgery I've been involved in for about 30 years now.
2 fellowships weren't enough. You had to do 3 fellowships. I believe we've got us an overachiever here, Jeremy.
Yeah, when I started reading the bio, I felt the same way, but we're happy about that. And, the topic today we're really going to be talking about is you have kind of put together, I'm not going to say for lack of a better terms, a system, but a way for folks to find out who is the best surgeon given their particular situation. And I really want to unpack that today because I think that's a much needed service out there that, a lot of, when you say laypersons, I think Sharon and I were talking about this beforehand. You go in today, you're having a colonoscopy and they find, a tumor in there, and typically that person is going to go to whoever, that particular person, that doctor who was doing the colonoscopy recommends them. But that might not always be the correct choice for them. So I'd love to unpack that a little bit more and hear kind of your viewpoint around some of the things you're doing.
Jeremy, you hit it right on the head. The problem, as I see it, especially in the surgical world, is the referrals. And what's happening today, you go see your primary care doctor, you have a condition, it warrants a surgical opinion, you get some diagnostic imaging, and he refers you to a surgeon who not necessarily has the best qualifications, but the referral's been made on the basis of habit. It's been made on the basis of a referral nurse that has a list of specialists that they usually refer to. Maybe the specialists are in the same medical office building. They have familiarity with that surgeon. But the referral is not being made on the basis of cost, and it's not being made on the basis of quality. And what I mean by that is the surgeon's outcomes. How many of these procedures the surgeon has performed? What's the complication rate? What's the success rate? Patients are totally blinded. They have a Blue Cross Blue Shield card, a Cigna card, United Healthcare card. They have a whole network of surgeons to pick from, but they get referred to and pigeonholed to a certain surgeon. And the result is this: patients are getting unnecessary surgery at an alarming rate. Depending on specialty, 15 to 30% of procedures performed today are unnecessary. Patients are also suffering from complications from unnecessary surgery. Patients are also getting connected to surgeons who don't necessarily have the best outcomes, having infections, wrong-sized implants put in, needing revision surgery, scar tissue. The system is a bit out of control. What we're doing with SurgiQuality is we're turning the tables so the healthcare system competes to take care of you. It just makes a ton of sense to us.
Well, why don't you talk a little bit about SurgiQuality, what you've set up and how it works? Give us some specifics around that.
Thank you. Yeah, SurgiQuality was an idea that I started, in 2014. But to give you some background, in 2007, I opened a surgery center and bundled a lot of the costs related to surgical procedures. So we were able to combine the surgeon fee, facility fee, anesthesia fee, for those who don't know, bundled all-inclusive pricing. It was very attractive. Patients had high deductible health plans. Patients had no insurance. It was really doing well, and that system was working extremely well. And I thought to myself, what we're missing is the surgeon outcomes. Every surgeon thinks they have the best outcomes, but do they really? So in 2014, we started SurgiQuality, and the platform has three different components. One is a personalized concierge service that handholds Mrs. Jones when she's been told she needs surgery. We have a medical record distribution platform, all HIPAA compliant, and with her permission, we gather her medical records, gather her MRI from the radiology facility where she had it. We upload these records to the cloud, and then we send the records and distribute the records to qualified surgeons in her network. They're all within her network. They get a chance to see her records, validate necessity, so important, enter their past experience, number of cases they've done, success rates, complication rates, and also all-inclusive pricing with their facility. So then Mrs. Jones, from the comfort of her home, gets multiple opinions, gets a list of surgeons that have seen her case and have opined on her case, and she's empowered with tools to compare surgeons and make well-informed decisions. Why wasn't the system built this way? It should have started this way.
Wow. No, you've hit the nail on the head. I completely agree with this. I mean, this is taking everything that's wrong with healthcare and trying to make it right. I mean, I really love this idea. I guess, the first question in my head is, one, where do you get your data? And I don't mean specifically, I just mean how do you do it? And is every surgeon in the country, willing to do this, take their time, look at the records, give that opinion? How does that work exactly?
Well, Jeremy, there's a whole movement right now with value-based healthcare.
Right.
And, CMS started this with their joint programs, which got curtailed at the end of last year, or maybe the year before. But there's a whole movement. And I can tell you that we're going to be moving away from fee-for-service to value-based healthcare. It's inevitable. So it behooves every surgeon to start gathering their data, how many cases they've done last year of the most common procedures, develop a metric, a quality measure for success and complication measures, and to start to access and aggregate that data on an individual basis. What we're doing at SurgiQuality is we're asking the surgeon their quality questions, that is, how many they've done, what's their success rate, what's their complication rate, and then we're taking that data, and the market is asking for validated data, not self-reported data. So we are corroborating that data with their medical record, and then we're comparing the cohort of surgeons and grading them appropriately with 1 star to 5 stars. And if surgeons don't want to report, Jeremy, that's all nice and fine. But the patients will be left to wonder why.
Right.
And I think, we need to bring more quality transparency to the marketplace and to the consumer so they make well-informed decisions. Don't you think?
Absolutely. Without a doubt.
Let me ask another question real quick about the data. You said it's not self-reported, but they're gathering it. And I'll give you an example where I'm going with this, because I do a lot of GI. Well, GI docs follow all their data. It is uploaded into a system called GI Quick that they started years ago. I would assume that GI docs were ahead of the curve as far as that is concerned. But is there anything like that for surgeons where they upload their data? I don't know that answer.
So we consider gastroenterologists surgeons. So that we consider them surgeons, not just proceduralists. So yes, GI Quick is way ahead of its time. They're collecting data on volume, they're collecting data on polyps, they're collecting their adenoma detection rate. That is how often a surgeon will find an adenoma or a tumor. Because as you know, Sharon, a good colonoscopist will find tumors about 20% of the time or greater. And if their adenoma detection rate is less than 20%, they're missing tumors. They're going too fast. They're doing 20 cases in a morning. They're going too fast and they're missing tumors. And that can be awfully catastrophic, right, to the patient, right? Just makes a ton of sense. We're going to ask very basic questions when we start. Volume is going to be key. And then we'll probably ask 1 or 2 other quality questions about centering around success and complications. So that's how we plan on starting in the marketplace.
Well, I kind of want to digress for just a moment and go back and talk about, COVID and how has that changed the landscape of healthcare today?
Well, Jeremy, it dovetails right into the book that I wrote, Resetting Healthcare Post-COVID-19 Pandemic, the Patient Handbook. Of course, the COVID pandemic has been a horror for families throughout the planet, no question. But there are some things that came out of that changed healthcare forever. The first thing that happened is that surgeries were put on hold in 2020. Sharon, you remember this. And a lot of procedures were triaged. All of a sudden, you couldn't have surgery unless it was really urgent.
Right.
So there's this surgical pause. And the other thing that happened, of course, is telehealth took off in a very big way, to the point where today you can have a virtual visit with any practitioner, any surgeon. It's possible. It wasn't possible many years ago. But with masking, vaccination, although there's a concern about variants, now the system is starting to open up. Surgery scheduling is starting to get restored to its pre-pandemic level in 2021 and beyond. There's going to be an explosion of cases being scheduled. It's a great time to reset healthcare. What do I mean by that? It's a great time for patients to pause. That is, they've been told they need surgery by a surgeon, but they really need to pause and then ask some difficult questions of their surgeon. Doctor, do I really need this surgery? Doctor, are there alternatives to surgery? What would happen to me if I didn't have surgery? And then they need to ask quality questions of the surgeon. They need to get smarter, and we need to give them intelligent information. Don't you think?
Absolutely. I think, again, this is what, we're hearing out of Washington. I mean, you talked about the values-based pricing and kind of where we're going. I mean, we all see the writing on the wall. I mean, whether you believe in a one-payer system or you think there's going to be some other anomaly that comes out of this, it's all going to come down to cost and quality. And how do you get the utmost quality for the least cost? And that's where we're going with this, whether it's the consumer making those decisions, as you've pointed out, or whether it's the health insurer or the government. Somebody is going to make those decisions as we move forward, especially when you've got a healthcare system that is as costly as ours in the United States, running about 20% of GDP. You've got to start making some of these hard decisions. Now, I'm sure there are people out there that want to keep the status quo, and I'll let you talk about that in just a minute. But, we were talking beforehand just even about the referral process and the flaws in that. I mean, there's a lot of flaws in healthcare right now. And as we kind of get into that, where do you think all this is headed as we come to, all these crossroads, cost versus quality? Where are we going with all this?
Well, this platform that we're talking about, SurgiQuality, is not a platform for all surgeons. It's only a platform for high-performing surgeons. Surgeons who are willing to look at the cost of their care, who are willing to work in facilities, perhaps in a surgery center or an endo suite, Sharon, as you mentioned earlier, and reduce the total cost of the service and demonstrate best outcomes. That is high ADR, whether it's colonoscopy, whatever metric you may want to use. And we talk about gallbladder surgery. We talk about bile duct injury rate. We talk about hemorrhage to the point where you have to open the abdomen to get control. These metrics are going to be extremely important. So we're looking for lower cost, high quality surgeons with best outcomes. That's where our sweet spot is. And that a successful surgeon on our platform will show those attributes.
Have you thought about what would happen if you weren't able to work for 2 or 3 years? On average, 25% of people will file a disability claim, and most of us aren't prepared for that loss of income. Every CRNA needs to protect their biggest asset, yourself, and your ability to earn with a disability insurance policy. We recommend contacting Robert Smith, a master disability insurance specialist with more than 30 years of experience and 1,800 CRNA clients, to find the coverage that fits you best. The best way to do that is to send him an email at rsmithjr@financialguide.com. That's rsmithjr@financialguide.com, or call him at 504-394-6557.
Let me ask you a question, and this has always been something I've wondered about, because you and I both understand that some patients come into the equation at different levels. America's not the healthiest population in the world, as we both know. How does that affect outcomes? Because if you come into an equation as a ASA class 4 versus ASA 1, you're more likely to have some issues post-op, and it might not have anything to do with the surgeon and their capabilities. It's just what the patient brought to the table. How do you handle that in outcomes? And there may not be a good answer to that. It's just something I've always wondered about.
Well, this is what I hear from surgeons all the time, Sharon. I hear, I only handle the hardest cases or the most difficult cases, so my metrics are going to be off. I hear that all the time.
Mm-hmm.
But we've got to come to a point, Sharon, where we're starting to compare apples to apples. So what do I mean by that? Tell me how many gallbladders you did last year, but tell me how many people you had with a BMI of a certain range. Those are the only ones I'm interested in, because the patient that I'm talking about has a BMI in this range. I'm not interested in your experience with morbidly obese patients with cholecystectomy. I'm interested in a BMI range that's in line with the patient that we're talking about. So, in other words, one surgeon came to me and said, Sanjay, I do a lot of malignant tumors of the parotid gland, the gland around your ear. And so my facial nerve paralysis rate is horrendous. I said, I understand that. I have a patient here with a benign mixed tumor, a benign tumor. I'm not asking about your malignant cases. Tell me about your benign cases. How many patients did you have with benign tumors last year? So we're qualifying the question. It's so critical. Otherwise, you won't be able to compare apples to apples. I think I made my point.
Let me ask you something, going down that rabbit hole. So if there's a surgeon who wants to be included in SurgiQuality, do you help them and guide them on what metrics they need to be pulling?
Absolutely. Yeah, we do guide them. We will give them common procedures that they do and the quality measures they should be looking at. It's going to be easy to do it early on, year 1, year 2, year 3, year 4. It'll get even more complex, to the point where we're really honing in on quality like nobody's business and providing transparency to the patient, which is so desperately needed, Sharon.
That's true. Jeremy and I were talking before you popped on here, and nobody ever gets a second opinion. Rarely. Nobody is too much, but most people do not. They just trust that their referring physician will know. And I had given Jeremy the example. We found a couple of tumors today while I was at work in the endo suite. And I asked, well, who do you refer your patients to? And knowing that I was going to be doing this interview with you today. And he said, well, I refer to the one who has the best outcomes. And I said, well, how do you know if they have good outcomes? How is that tracked? And he said, well, if I never see the patient again, then it was a good outcome. And I'm like, well, I'm not really sure that that's the best way to do it. And I have another endo doc that I work with, and I asked him the same question after we had decided we were going to have this conversation with you. And I do work at an area hospital also, and he was referring to a physician I would not have necessarily chosen, because I'm in the operating room and I see skill sets, I guess you could say. Now, I will say I don't necessarily see outcomes, because after they leave my care, I usually don't see them. But I still know a surgeon's skill set whenever I'm in there. And, I base that on how much blood they lose, or how the patient does in the operating room. I know how a surgeon is. There's an old saying, a good surgeon needs a good anesthetist. A bad surgeon needs an excellent anesthetist, because we'll keep you from killing them.
Well, that brings me to the story I've got to talk to you about, because there was a surgeon in an academic center, and it's in my book, this story, who was doing gallbladder surgery. And he was very, very well known, and he was getting cases referred from all over the world, right? And it's very interesting. The surgeon trained at the time of open, gallbladder surgery. So he would open the abdomen to get control. That's the time that he trained. He learned laparoscopic skills during his practice. And it was very interesting because he was losing a lot of blood, and there would be transfusions. The best anesthesiologist would always do his cases. And then finally, one day, there was a death from hemorrhage, and that shook the whole hospital. So patients think they're getting the best care going to name brand institutions, but are they seeing the experienced surgeon with best outcomes? Are they seeing the fellow that just finished his training? Are they seeing the scientist clinician who's spending 4 days a week doing basic science research, 1 day doing clinical? These are all things that patients don't even know, don't even think about, but these are the realities of medicine today. And remember, the third leading cause of death in the United States is medical errors.
Wow, I didn't realize that. Third leading cause of death. Sharon, did you know that?
Yes, sir.
Wow, I did not know that. That's really interesting.
More than guns, or it's pretty close.
Right. Cancer,
Maybe we don't need gun control. We need surgeon control.
That'd be a great T-shirt, Sanjay. You should come up with that. I like that.
Oh, Sharon. You got to be in certain parts of the country to do that.
That is true. That is true.
That'll be your T-shirt, Dr. Prasad. Surgeon quality, or gun control, or surgeon control.
So Sanjay, I've got another question about this because it's just popping in my head. Like, who pays for this to be in SurgiQuality? Is it the surgeon? Is it the end user consumer? Are insurance companies hopping on the bus with you? I mean, how does that work?
So we're selling this platform, Jeremy, to self-insured employers.
Okay.
And although fully insured employers can use the platform as well, but it's the self-insured employers that are ascribing to the service and paying a subscription fee per employee per month.
Okay.
We don't charge the surgeons. We don't charge the surgery centers or hospitals. Look, our aim is to lower the cost, right? That's where our aim is, and to improve the quality scoring. And I can tell you that even the big major insurers are very interested in what we're doing. Mm-hmm. They also want to connect their members to the best-in-class surgeons in their network. So we're all on the same page. This is a win-win-win all around.
Beyond the Mask is made possible by the team at CRNA Financial Planning. With almost 2 decades of experience, the firm guides CRNAs through the complexities of investing and financial planning. Schedule a free consultation today by calling 855-304-3748 or go online to crnafinancialplanning.com.
What percentage, and you might not know this, but I'll just throw it out there, in the U.S. of companies are self-insured, since that seems to be a little bit of your target market?
It used to be that all companies basically over the 500 employee mark were 95% self-insured. I think it's getting closer to 98%. And I can tell you that even the smaller companies with 100 employees are finding themselves in a self-insured environment. So it's just making a ton of sense to try to control cost containment measures, and improve quality scoring. So, the population is pretty vast. And we have a situation where we've got a Fortune 100 company that wants to use our platform. We're very excited in the coming months of what's going to happen. There's just a lot of excitement in our company.
So just for our listeners who might not exactly understand the self-insured side of things, my understanding of this, and it's not very vast, but basically you've got a larger employer who decides to cover up to a certain amount of healthcare dollars per year out of their own pocket, and then they have like a reinsure if they go over that amount. Is that kind of the gist of the way it works?
Yeah, you got it. The premium dollars flow into, and this is what I talk about to surgeons who don't understand, want to understand, right? Premium dollars from the employer and employees flow into a capital reserve account, and it's protected by a reinsurance or a stop loss. You can call it stop loss. And there's typically a third-party administrator or an ASO within an insurance plan that administers the claims and pays the claims out from that capital reserve account. So it's a whole dynamic process, and it can be either insurance company controlled, which we called an ASO, or it can be called an independent TPA type system, where a TPA kind of has control over how the plan functions. So there are two different ways.
Well, as you were just talking, my other initial thought is, have you ever thought of going up to Capitol Hill and explaining this to them so that maybe Medicare would get your services and do the same thing, or you think they'd kind of steal your idea and run with it on their own? And you know how well they are at implementing ideas. So
look, we're here to implement the solution. So Medicare is very interested in the platform. They just want to see a scale.
Yeah.
And that's all nice and fine. The Medicaid population would do very, very well with this. There's no population that won't do well. I mean, internationally, the UK with the NHS, they would do well. Germany definitely could use some help. This is a great system. It's a wonderful system.
Yeah. Well, I think it's very interesting. Sharon?
I'm sure you're tracking your metrics about how much the cost savings are. So when you market your idea to these companies, you already have that data. It might be new data. Can you expound on that or share some of that information with us?
Yeah, based on the information we have so far to date, we're able to save about $3,000 per surgical procedure. And please remember that when I say cost of a surgical procedure, I'm including surgeon fee, facility fee, which is a big part of it, anesthesia fee, which is a very small part of it, pathology fee. I mean, it's all inclusive. But I will tell you that most of the savings, Sharon, are occurring from changing the site of service from a hospital system to a surgery center, so to a surgery center. That's where the main savings is occurring. And of course, there are implants and, number of shoulder anchors they're putting in. Is it necessary? Is it not necessary? Some are more conservative, some are more liberal. It's all across the board. But that's the advantage we have right now in terms of price competition.
So I'm looking at all this, and I'm looking at you, Sanjay, and it seems like your life has kind of come full circle at this point. Here you are coming to the U.S. and, you're coming here for medical reasons and, trying to find the right surgeon. And here you're a surgeon, and now you're developing this system out to, make sure that other folks are getting the correct surgeon for them. And I applaud you for doing this. This is a very noble. Hopefully for me, I hope you make money off of it at some point as well. But it's very noble, and you don't find many people that have done that. And I would like to hear a little bit more about your book, Resetting Healthcare. We've talked about a really small sliver here, and I know we've just got a few more minutes with you, but I'd love to hear a little bit more about that and the whole idea behind it.
The idea behind it was to educate consumers. It's the patient handbook. So it's for patients to understand, what's happening in the marketplace today, what happened with COVID, the changes in healthcare that happened, the opportunities that are before us to improve the system, right? And Jeremy, you put it right on the head. Look, I'm 60 years old, right? And I want to leave us a healthcare system we can be proud of for the next generation. That's what it's all about. It's about leaving something behind for your kids, your grandkids, so that the system works for them. That's the whole mission.
Let me ask you another question about SurgiQuality itself. How long did it take you to build this platform?
Sharon, it took a while. I'll tell you why. We started in 2014, but, the cloud wasn't ready. The healthcare cloud was just developed. It became HIPAA compliant recently. Electronic medical records hadn't been around. I mean, meaningful use helped with the development of electronic medical records to the point where it's implemented. Virtual visits are now here because of COVID. It's the development of the whole ecosystem of healthcare IT that's allowed this to happen, Sharon. The time is now. There's no question.
Absolutely, Shane. We always talk about this. This is we're at a crossroads. Where do we go from here? Again, back to what you said, values-based, cost versus outcomes. These are things that, a lot of physicians in general haven't had to do. And I imagine that there are folks out there that, are given a lot of pushback on this because they're having to track and they're having to disclose stuff that they might not have wanted seen out there before. I mean, my wife is a CRNA as well, Sanjay, and, I hear her kind of, even to Sharon's point, she was telling me about today at work, and there's this one particular surgeon, and she said, gosh, he's horrible. For an hour-long procedure, it takes him 3 hours, and, it's like he's not a very good surgeon. And I have a feeling that the more this gets disclosed out there, people that might not be as good, they're going to feel a little crunch from this.
Jeremy, they will feel a crunch, but the system, we're all about re-education. Maybe a surgeon who doesn't have the best outcomes, maybe they need some proctoring, maybe some retraining. Come on, they've spent quite a few years of their life getting to a certain spot in their career,
right? And
maybe they just haven't kept up. And I've got to believe there's plenty of opportunity to retrain and to improve their quality scoring. And what a beautiful benefit that is for the rest of the country.
Absolutely.
So what would you like to leave our listeners with as we wrap up here?
Your listeners, as I understand it, is mostly CRNAs and hospital workers and hospitalists and surgery center personnel. Is it? Do I read that correctly?
Yes, that's the majority.
Yeah, I think that the message I would leave is this. We could sit here, and value-based healthcare will come before us by the government, and they won't understand the system, they won't understand healthcare, and they'll put rules before us that will be untenable. Or we can take the bull by the horns, and we can look at our own quality scoring, our own success measures, and complication measures, start aggregating and taking less performing surgeons or facilities and make them better so that we can build the value-based care system from within. That makes a ton of sense to me. I'll leave you with that thought.
Yeah, well, I would challenge you to think the government's already doing that anyway. So I applaud you for starting from the inside out.
I agree. I mean, I think there is a lot in this short 30 minutes that we've been together, but, our listeners that want to learn more can get Dr. Prasad's book, Resetting Healthcare, and we will put that in the show notes along with a link to his company and contact information. A lot of our CRNAs obviously know a lot of surgeons out there, and maybe they'll pass the word along, and, maybe we can help start even more of the movement that you've already done.
Great. Thank you, Jeremy. Thank you, Sharon.
Thank you. Thank you for being on today. Thank you for the great work that you're doing out there, not only for patients, but it sounds like even for humanity in general. And you seem to have a really good heart and driving factor for this, and that comes across. I want to thank you for that today as well. Sharon, I think it's a wrap.
I think so.
So we want to thank our listeners for listening to Beyond the Mask with Jeremy Stanley and
Sharon Pierce.
I thought you forgot your name for a minute there. You paused on me.
Only for a second.
You worried me for a minute.
That Prevagen's really working for me now.
All right. So if our listeners want to know more about our show and help us out, Sharon, how can they do that?
Well, one of the best ways they can help us is to leave us a review because it pushes us up in the algorithm, but only if it's
positive. There's enough negativity in the world.
Absolutely.
All right. Until next time.
It's a wrap.
As a CRNA, you spend years preparing yourself for this career, so we don't want to see you lose out on any of the income you've worked so hard to earn. The best way to protect yourself and give you the confidence that a major life event won't disrupt your financial future is through disability insurance. We've known disability income specialist Robert Smith for many years and have seen the work he's done with nearly 2,000 CRNAs over multiple decades. He can help identify any gaps in your existing coverage and fill those gaps by finding the best value on a policy. Contact Robert and let him know you heard about him on our podcast. Send him an email at rsmithjr@financialguide.com. That's rsmithjr@financialguide.com. Or call him at 504-394-6557. Protect your greatest asset as a CRNA, yourself and your ability to earn a living, by adding disability insurance to your financial plan. Today's show is brought to you by the folks at CRNA Financial Planning, an independent consulting firm that offers financial planning services exclusively to CRNAs and their families. From planning for a child's future college expenses to building a predictable income stream in retirement, the firm is committed to offering you comprehensive financial services, customized to fit your unique needs and objectives. If you have questions about your financial future, get them answered. Call the team at 855-304-3748. That's 855-304-3748. Or go online to crnafinancialplanning.com.
Sharon, the season of Christmas and giving is upon us again.
Yes, it is. And it keeps coming around quicker and quicker.
It certainly does. And during this giving season, you and I and our listeners have an opportunity to give two ways at once. As many of you know, Sharon and I support the ANA Foundation, and I currently serve on their board. The foundation is a charitable organization devoted to anesthesia research, education, and development.
All of which are very important to our profession.
That's exactly right, Sharon, and it's the very reason to donate. However, we wanted to let you know that you can give to the foundation during this season in someone's honor as a tribute, or if you've lost a loved one, a donation in their memory. The foundation will send a card to the family letting them know that you've done this.
What a lovely way to memorialize someone. You know, I will be donating in memory of my precious granddaughter, Emma Kate Brecken, that we lost this year. Also, as we're taping this, we found out we lost an icon to this profession, Patrick Downey, a former AANA president. Another way to memorialize him is to donate to the foundation.
Yes, Sharon, and I really hate we didn't get an opportunity to have Patrick on the podcast. That was always our plan. It's just so sad. If you'd like to donate, just go to the ANA Foundation within the AANA website under Ways to Give and donate in tribute or in memory and help your profession.
Thanks so much, and Merry Christmas from myself and Jeremy.
Hi, this is Jackie Rolls, President of the International Federation of Nurse Anesthetists and President and founder of Our Hearts, Your Hands, a global anesthesia support community that takes donations to allow nurse anesthetists in low and middle income countries to go to educational programs, buy equipment, or textbooks. Your donations are tax deductible, and we would appreciate your support.
OSA EMR is a free anesthesia EMR developed by CRNAs that you can download and use on an iPad. Our nonprofit mission is to make sure that solo and small practice CRNAs can digitally record their anesthetics. To learn more, visit osaemr.com to download and consider donating to our cause. Remember, for CRNAs, data is destiny.
Be sure to subscribe to the show on Apple Podcasts, Google Podcasts, Spotify, Stitcher, and anywhere you like to listen to shows. Also be sure to check out BeyondTheMaskPodcast.com. Each episode is posted there with a corresponding blog post, and we timestamp important parts of the episode to help you quickly get to the content you're looking for. Also check out the special series section on the site. You can follow along and catch up on the CRNA History Series, episodes specifically about political conversations in the industry, or try the CRNA Personal Finance Series. It's all on BeyondTheMaskPodcast.com. And if you have a question for the show or want to be a guest, or even suggest a particular topic, fill out the contact form on the site or send an email directly to us at info@BeyondTheMaskPodcast.com. And lastly, let's take the conversation social. Check out our Beyond the Mask podcast Facebook page and Facebook group.